Namaste. At the outset, let me thank the Medivision and Dr. Shubram and all the members who have invited me for this Facebook live session on stroke. Stroke is one of the leading causes of morbidity and mortality in the country. If we go to the statistics, worldwide, every 1 in 4 persons will be affected by stroke in their lifetime. In our country, every 20 seconds, someone is affected with stroke, and every 4 minutes, somebody dies of stroke. Over the last 1.5 decades, it has been seen that the number of stroke cases have increased by around 17%, and the mortality of the stroke has increased by 7%. So we can realize that the burden of the stroke is very large. When the burden of the stroke is very large, it is mandatory that we understand how to take care of stroke patients, and moreover, as time has changed and as treatment has been revolutionized, the stroke treatment with the newer modalities of treatment, now we can see that the morbidity as well as the mortality of the disease can come down to a large extent. Now let us learn about stroke first, and let us classify stroke. Now stroke can be divided into two broadly. One is the ischemic stroke and one is the hemorrhagic stroke. If we see the ischemic stroke, that is when any transient neurological deficit, either in the retinal or in the brain or in the spinal cord, due to decrease in the blood supply to the brain, is ischemic stroke. And the other part is hemorrhagic stroke, which includes the intracerebral hemorrhage, and it also includes a subarachnoid hemorrhage. The ischemic stroke includes around 80% of the stroke patients, and the hemorrhagic stroke includes around 15 to 20% of the patient, of which the subarachnoid hemorrhage is including only 5% and the intracerebral bleed is only 15%. So now we are going to talk today predominantly about the ischemic stroke. When we are talking about ischemic stroke, it is also important that we understand about an entity called as the transient ischemic attacks. Now what is transient ischemic attacks? As I said, for the ischemic stroke, the definition is neurological dysfunction either in the brain or in the retina or in the spinal cord, which is due to decrease in the blood supply. The word transient ischemic attack itself implies that transient, that it is there for only a few minutes, hours. But then it is equally important for us to recognize the transient ischemic attack, because a percentage of patients within a week or within a month can go on to develop a full-blown attack. Now we have completed about the classification of the diseases. Now any patient who comes with an ischemic stroke, and today we are going to talk about only ischemic stroke, any patient who comes to you with an ischemic stroke, there are 3 major questions that we need to address. What are the 3 major questions? One is whether is it a stroke, or is it a stroke mimic, or whether it is a stroke chameleon. Now what are these 2 words which we have say? Stroke mimic means a patient who comes with the symptoms similarly like that of a stroke, but it is not a stroke. And what is a chameleon? A chameleon is any patient who comes with the symptoms which look like any other disorder, but it is a stroke. So the first thing, as I said, three things which we need to look into as soon as we have a patient of stroke is whether it is really a stroke, or it is a chameleon, or it is a mimic. That is first. Second, which area of the brain is involved and which arterial territory it is involving. Third, what is the causative factor for the stroke? So that is, what are the risk factors that could have brought the stroke onto the patient? That will help us to see the treatment modalities in that patient. So let us come to the first question. Is it really a stroke? Now the most important stroke mimics, as I said, mimic means patient has symptoms which is looking like a stroke, but it is really not a stroke. One of the most important stroke mimic is a seizure and a Todd's paralysis. So the other mimics are the seizures. It could be a syncope in a patient. It could be infection or a patient with sepsis. There could be metabolic disturbances, like the patient could be having hyponatremia, patient could be having hypoglycemia, the patient could have migraine with aura symptoms on the patient, they could be having drug overdose, the patient could be alcohol intoxicated, patient could have Bell's palsy, the patient could have a tumor, or patient could have an SDH, and the list is so long. But let us discuss at least one or two points which we should not miss. One is the seizure and Todd's paralysis. So most of the time what happens is that the patient has got a seizure, and the seizure, the event, that is the fit, is not witnessed, but post seizure the patient has something known as weakness of one side of the body, and that is known as Todd's paralysis, which can last up to 24 hours in any patient. So patient is brought to the hospital in the form of a weakness which looks like a stroke. The second is a syncope, that is a patient suddenly falls down, and it mimics like a stroke in the form of a vertebrobasilar insufficiency, that is a posterior circulation stroke. However, in that situation, the patient has got usually before the syncope, the patient has got pre-syncope events. If it was a classical cardiogenic syncope, the patient can have fluttering, and the patient can have palpitations, sweatings, which could have preceded the syncope. The seizure with the Todd's paralysis can also be clarified if the patient is carefully examined and the patient has got a tongue bite, especially if he has a tongue bite on the lateral side, which is very classical for a generalized tonic-clonic seizures, and then the patient has got a Todd's paralysis. Sepsis, hyponatremia, hypoglycemia definitely needs investigations once the patient enters the hospital, and if the patient has got a hypoglycemia and it mimics like a hemiparesis, immediately a 15%, 25% dextrose which is given to the patient will recover his symptoms, which in itself tells us that it is a hyponatremia, it is a mimic of the patient. Then there are other conditions. As I said, the patient has a migraine with an aura. So what we understand from migraine with aura is the patient has got scintillating scotoma, so they can have round black and white or colored objects, but they're all positive, And in a stroke patient, it is usually negative symptoms. Either the patient loses vision, either the patient has blurring of vision, but in a migraine with an aura, it's more of positive vision. The other mimics are for drugs that we need to take the history from the patient. Alcohol intoxication, we need to take the history from the patient. The brain tumors or the other things, which as I mentioned to you, it could be that needs to be seen by the imaging features. So that is about the mimic. The patient has come to the hospital. You have ruled out the mimic, and now what is chameleon? The chameleons are the patient really has a stroke, but his symptoms are such that we feel that he could not be having a stroke. Most cases, what happens is it's usually the patient has got blurring of vision, or the patient is not able to see properly, and the patient usually goes to the ophthalmologist. That happens in bilateral occipital infarcts, where it is known as the Anton syndrome, or patient has one-sided occipital infarct and patient has a hemianopia hemianopia, which tells us that the patient has got visual disturbances which is cortical in origin rather than ophthalmic in origin. Other is in the bilateral thalamic regions of the brain, in which the patient has got amnesia and he loses his memory, and the patient comes to you with dementia, and the patient is streamlined to another sort of investigation modality. So bilateral thalamic. bilateral occipital or unilateral occipital. There is something known as a limb shaking TIS, in which the patient just has jerks like this and then it subsided, again has jerks like this and it subsides. It usually happens if there is any of the side carotid severe stenosis. The patient has got hypoperfusion, especially when the patient gets up and then has some jerks, and then the patient stabilizes, the jerks stop. It looks as if the patient is having a seizure, but they are known as limb shaking TIS. Sometimes the patient has only got one arm weakness, just has a wrist drop or just has a foot drop, and could be having a small lacunar lesion in the brain. So the first part is done. We have seen that the patient has got a stroke. He doesn't have a mimic. He doesn't have a, the patient doesn't have a stroke chameleon, and we have ruled out and it looks like a stroke. Now the second thing comes that we need to see which part of the brain is involved and which arterial territory it is involving, of which I'll allow me to show a small video. Now this is a circle of Willis, and if we can see, and this circle of Willis is what rules out our, the whole brain has got a clear-cut anastomosis from up, that is the anterior cerebral veins. These are the carotid vessels. These are the bilateral vertebral arteries forming the basilar artery. So this is a circle of Willis, which usually the left side and the right side of the brain are not supplied, are not taking blood from each side of the brain. But in case there is a stenosis at some point, the collaterals form and the brain itself sees that the perfusion happens from the other side. That is why the circle of Willis is very important. But these are the large vessels, and you would see that there are certain small vessels as well, and these are the ones, and these are the small perforators. So this is the vertebral, this is the basilar, this is the posterior cerebral artery, these are the bilateral internal carotid artery, this is the anterior cerebral artery. So what we are seeing here is this is a circle of Willis, that is anterior communicating artery, the posterior communicating artery, and the carotid arteries, and the bilateral PCA, which forms a nice circle which has been described to understand the supply of the brain. Now, if you look at the brainstem itself, their classification, then the structures which involve and produce that is divided into various parts. So if we see the cerebral artery, that is the internal carotid artery, the middle cerebral artery, the anterior cerebral artery. So what are the main features that the patient presents to you with if the patient has got an internal carotid artery? So either the left or the right. So the left side predominantly supplies the language for you, and the right side is predominantly concerned with the neglect. The common features among both would be homonymous hemianopia. The patient can have, patient will have contralateral hemiparesis, hemisensory loss, and dysarthria on the right side. What would be very common for the large vessel artery is also that the patient will have gaze deviation towards the opposite side. So he will look at the side of the stroke. If it is a middle cerebral artery and the anterior cerebral artery, the middle cerebral artery will have all the features of contralateral hemiparesis, hemisensory loss, homonymous hemianopia, and aphasia in form of left-sided lesions, and in the form of right-side hemispheric lesions, it could be neglect. In an ACA territory, the patient has got more of leg weakness than arm weakness and will have frontal lobe symptoms in the form of ebulia. The patient will be apathetic, and if it is bilateral, that can be a kinetic mute. So that is the anterior circulation that is supplied by the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery. Now, if we talk about the vertebrobasilar system, that is the posterior circulation, it will have predominantly the lower cranial nerves, which starts from the 7th and the 8th, and the lower cranial nerves, which are responsible for the swallowing. And it will also have predominant symptoms of vertigo as well as imbalance of gait and drowsiness and coma. So in general, if at emergency level, if we want to distinguish between the anterior circulation and the posterior circulation, The history wise, the posterior circulation will have more of vertigo and imbalance of gait. Clinically, examination wise, the patient will have inner posterior circulation. If the patient presents with bilateral weakness, it could be from the medulla because of the crossed corticospinal tract involvement. There could be crossed hemiplegia, which is very classical for brainstem lesions. That means that he will have cranial nerve involvement of one side, and crossed hemiplegia, that is the corticospinal tracts have crossed and that involving the hemiplegia or hemiparesis on the opposite side. The patient will have dissociate sensory loss, that is involvement of only the pain and temperature, that is the spinothalamic. Especially seen in medullary lesions, you would see that patient has got facial hyperesthesia and opposite side, the upper limbs and lower limbs having hyperesthesia. That is again crossed. The patient can have fifth V1 and V2 sensory symptoms, again posterior circulation, pointing towards the posterior circulation stroke. The patient can have Horner syndrome, that we said that the patient can have in the medullary lesions, the patients can have Horner syndrome. Certain cranial nerve deficits, which classically points out, as we said, lower cranial nerve palsies, lower cranial nerve facial nerve involvement. As we mentioned in the anterior circulation, when the patient has a stroke, the patient looks towards the side of the lesion, that is the gaze is towards, if they has got a left-sided cortical infarct producing a right-sided hemiplegia, then the patient's eyes will look towards the left side of the brain. But if it is a brainstem lesion, then the patient's eyes will look towards the side of the paralytic side. If the patient has got a right-sided paralysis and his eyes are deviated onto the right side, then we know that we are dealing with a brainstem lesion. Then then the patient, as I said, they will have a lot of cerebellar symptoms. So the second part is done, and we have seen that it is a stroke patient. There are no mimics, there are no chameleons. The patient's arterial territory, we have seen whether it is an anterior circulation stroke, whether it is a posterior circulation stroke. We have broadly classified them. Then the third part comes of what are the risk factors, why did he develop a stroke? So for that, there is a classification known as the TOAST, that is the Trial of Org Stroke Treatment, in which it is divided into 5 according to the reasons. That is a large artery atherosclerosis is 1, TOAST 1 classification. TOAST 2 is small vessel occlusion. TOAST 3 is cardioembolic. TOAST 4 is undetermined and uncertain. So in this, the first is the large vessel. As I again come back to the circular villus, which is very important. It's also very important. I'll come to you when I speak to you about the treatment part, because the large vessel is the vertebrobasilar, that is the 2 vertebrals, and the basilar, or the internal carotid artery, or the stem M1 part of this middle cerebral artery and the anterior cerebral artery. If they are blocked, the most common reasons for them are either it is a hypertension, the risk factors which are modifiable are hypertension, diabetes, dyslipidemia, smoking, smoke years for the patient, alcohol, obesity, especially the truncal obesity, lack of exercises, and several other features, several other situations like snoring, obstructive sleep apnea, which can increase the atherosclerosis for the patient. Second one is the small vessel occlusion, in which, as I said, that there are certain end-on arteries. These are the small perforating arteries which can come from here, which come from here, and which come from the middle cerebral artery. If we draw a line, the menticulostriate arteries, they are due to lipohyalinosis and mostly due to hypertension, diabetes, and the conventional risk factors. They produce the small vessel disease. Again, clinical is very important, and we need to know the clinical scenario. They produce classical lacunar syndromes. That is either a pure motor, either a pure sensory, either a sensory motor, or an ataxic hemiparesis. So you look at the patient and the patient has got a pure motor paresis, you know that it is a lacunar syndrome. When we know it is a lacunar syndrome, then we know it is a lipohyalinosis. We know that there are large vessels of the body, of the circular vessel might not have been involved. Third is the cardioembolic, which is very important because in which the valvular heart disease, the rheumatic valvular heart disease, the atrial fibrillation, the cardiomyopathy, ischemic heart disease, any of these symptoms which are related to heart, which send the embolus from the heart to the brain could be the reason. Then the undetermined and the other causes we talk about the hypercoagulable disorders, the vasculitis, the connective tissue disorders, and the thrombophilic disorders. All these comes under. So when we are investigating the patient, when the patient comes to your hospital, when we see that, and when we have removed, when first we see the clinical scenario. So the patient has got a large vessel occlusion, then we know that the patient will have a large stroke. Clinically itself, we know that he has got a large stroke because how? He would have an aphasia, he would have a neglect if he's on the right side, he will have a homonymous hemianopia, and he would have the classical cortical syndrome, which tells us the patient could have a large vessel occlusion immediately as soon as the patient has come to the emergency itself. So it is very important when we are seeing this. So that is the three parts we have covered. First part, whether it is a stroke. Second part, whether it is the arterial territory and which part area of the brain is involved, and the risk factors which could be leading to the stroke. Now we come to the treatment part of the stroke, and let me take you through a small case scenario so that it is easier for us to understand, and probably you could ask me questions if there are any from your side. Now let us assume that a 65-year-old gentleman comes to the doesn't come to the emergency, develops a left-sided hemiplegia and dysarthria, and patient has got a blood pressure of 210 by 110. He is at his house, and you are there nearby, and patient is brought to the hospital, and they call you. Now, so if anybody wants to ask a question as to what you would do, if there are any persons on the live. So if the patient comes, if you are called as an aspiring doctor, the patient's blood pressure is 220 by 110. The patient has got a stroke. It's quite clear. The patient has got a hemiplegia and patient has got a dysarthria. It became sudden in nature, and so everything is clear. He's got a stroke. Would you want to decrease the blood pressure? Because he has got an accelerated hypertension, 220 by 110. If I can have some comments on this, if anybody would want to reduce the blood pressure. Okay, yeah. So if a patient has got an ischemic stroke, or if a patient has got a stroke, until and unless you do a CT scan or an imaging, you wouldn't know whether it is an ischemic stroke or a hemorrhagic stroke, which we have seen in the beginning. Though the blood pressure may be very high, but it is really not possible clinically to know whether it is an ischemic or a hemorrhagic stroke. As I said, from the TOAST classification, we can find out whether it is large vessel, whether it is a lacunar syndrome, all this we can find out. So if any person has got this scenario, the patient should be immediately shifted to a hospital which has got stroke treatment modalities in place. That is a comprehensive stroke care center. Why do I say that the patient should not be taken to a first aid to a nearby hospital? Because every minute that the patient started having a stroke, every minute 1.9 million neurons are dying. So if we waste time, so let me show you what happens. Again, let me make use of this. And if, yeah, so I think it's clear now. Okay, I'm sorry. Yeah. Yeah, so if you will see that red block there, that is the amount of stroke that the patient initially had when the patient developed the symptom. And the light pink color which is there is the penumbra area. So let me show it in this. If the patient develops a stroke, this is the small area which is the core part of the stroke. There is an area over and above it in a circular manner that is known as the penumbra. And over and above it, there is an area that is oligemic. So this core area has got only 6 to 8 ml per 100 100 grams per minute of blood supply going. Now this area which is surrounding it, that is the penumbra area, that is the pink area which I showed you, that has got 8 to 20 ml per 100 grams per minute blood supply going. And there is that oligemic area. So what is our intention is, the core area should remain the core area, and we need to salvage and protect this penumbra. So if we do not, let me just adjust the lighting a little bit. Yeah. So this is this we see is the core area, round red color, and we see is the pink is the penumbra. If we do waste time and we see that the patient is not given treatment, then the core area keeps increasing, and you can see now the stroke area has become very large. So time is brain. Every minute 1.9 million neurons are being lost if the patient is not being treated properly. And now what is treatment and what is that time? The time in 1995, the first thrombolytic therapy for stroke revolutionized the stroke therapy. As I said, ischemic stroke, only for ischemic stroke we are talking, as I said again, if there is a block in the blood vessel, as we said in the large vessel disease, the first type of classification, if we give a thrombolytic therapy, that is known as the clot busting therapy, in a large percentage of patients, around 30% of patients, the symptoms can be reversed, or the patient's morbidity can be reversed to a large extent, if not then at least a 3-month period time. So why not give the thrombolytic therapy to everybody? That is not possible because one, it is given only for ischemic stroke. It is not given for hemorrhagic stroke. Second, there are certain indications and contraindication. One is time. So time is brain. If with the last photo which I showed you, if the patient comes with this, that means the patient has already crossed the golden window period, that is the 4.5-hour golden window period of stroke treatment. The thrombolytic therapy cannot be given to that patient. Second, there are certain contraindications. If the patient has got any bleeding diseases, the patient has got a tendency to bleed, the patient is on any blood thinning tablets like anticoagulants for the heart, in which if we give the thrombolytic therapy, there can be a bleeding. The patient has got a recent surgery in the past, the patient has a recent head injury, the patient had got a recent intracranial bleed, and his blood pressure is very, very high, or his blood sugar is very high, which cannot be controlled during that window period of 4.5 hours. The door to needle time, that is what we say in our neurological stroke treatment. Door means when the patient reaches the door of the emergency. Needle means when the patient gets the thrombolytic therapy is around 1 hour. So when the patient comes to the hospital, it takes 1 hour for the stroke team and the emergency team to evaluate, send him for the blood test, send him for the scanner to find out what are the indications, the contraindications, counsel the relatives, because it is not that the treatment is not without side effects. There is a 1 to 4% possibility of an bleed. Because it is a thrombolytic, it is lysing the clot, it is thinning the blood, there can be hemorrhage elsewhere in the body as well. And that could be in the either in the urinary tract, he can have hematuria, it could be nasal bleed, or it could be any sort of ENT bleed, or it could be a bleed inside the brain. So we have our patient, he had symptoms at 1 hour, he came to the hospital, so he should not have been given any antihypertensive, he should be triaged to the stroke care center, a comprehensive stroke care center, where all these things will be done within the door to needle time of 1 hour, and we can see that maximum benefit is given to the patient. So let us imagine that he was given the maximum benefit and then he didn't improve. So is there any other way to help him out? Yes, the stroke treatment has again revolutionized. There are 2 major trials which have shown that within the period of 4.5 hours from the stroke to around 8 to 12 hours, and in some cases more than that, endovascular procedures can be done. In some patients, as I showed, if the large vessels, that is a carotid or the M1 segment of the MCA, if they are blocked and they have not been recanalized, the patient can have endovascular treatment done, that is taking the clot by devices which helps us to recanalize the vessels. So the stroke treatment modality has changed a lot. There is a time window, and time is brain. For the general public to know, and as doctors and budding doctors, what you should tell to them is recognize the stroke symptom, and the most common mnemonic which has been given by the WHO is the FAST, that is FAST. For them to recognize, F is for face, that is any facial deviation. A is for arm, that is any weakness of one side. S is for speech, that is either speech disturbance, either he is dysarthric, he's not able to talk, or he becomes mute, he doesn't talk at all, or he has got aphasia in the form of Wernicke's, where he is blabbering and he is having confusional talk. Two other symptoms which is very important as people who could be caretakers of stroke patients as, one is amaurosis fugax and one is the posterior circulation visual disturbance, which most of the times get missed out and the patient lands up in the ophthalmologic department. Why it is important? Amaurosis fugax, it is transient monocular painless visual loss, that is transient monocular, one side. If the carotids of one side are blocked, they will have multiple episodes, 3 to 4 in a day, in which they will have visual loss of one side, one eye, and it will fall like a curtain, and then it will just move off like that, and then they will be normal. So if it is not treated in time, the patient can have a full-blown attack at that point of time. After the treatment of thrombolysis or the endovascular procedures has been done, the patient would require regular physiotherapy, rehabilitation, speech therapy to come out of his deficit and to see that he comes back to his normal life. And he also requires antiplatelet and statins apart from his antihypertensives and anti-diabetic medications, which needs to be lifelong. A recurrent stroke is very common in patients who do not follow these rules, and that leads to increase in his symptoms that can lead to a lot of complications, because the patients who do not do regular physiotherapy are prone to pains, spasticity, depression, and dementia. But if treated in time, if recognizing the stroke risk factors, curtailing the stroke risk factors at the primary level, responding to the stroke symptoms immediately, and reacting and reaching to the stroke center, can go a large way to see that stroke patients' morbidity as well as mortality can be reduced to a large extent. I thank you one and all for the patient hearing, and if there are any questions, I will be happy to take them. Yeah, there is a question: if there is going to be a delay in reaching the hospital, should the family do any first aid to reduce the damage of the brain? I would say that stroke doesn't have a first aid, but it would be very wise that you can pick up the ambulance services of that hospital to take you to that hospital so that the triaging can be done. The ambulance people, if they are accompanied by a technician or a duty medical officer, they will in turn check the patient, they will check the blood pressure, they will check the sugars, they will check the patient's condition, and they will have the details of the patient which will be told to the emergency, which will reduce the time where we can help in triaging the patient to the radiology department faster. So yes, I had got some answers very rightly, that whether we will reduce the blood pressure, we will not reduce the blood pressure, because the cerebral perfusion is maintained on that blood pressure. That is known as the auto-regulation of the brain. Unless it is a malignant hypertension and it is producing a cardiac failure, or it is a coarctation of aorta, any of those emergency medical situations, we do not reduce the blood pressure to a drastic low. So the most of the times it happens that as a first aid, the patient is given a sublingual nifedipine, and that can reduce the blood pressure to very low. And that amount of perfusion, we have already shown, this is the core, this is the penumbra, and this is the oligemia. That perfusion is with that blood pressure which the patient is maintaining. If you reduce the blood pressure still further, the perfusion decreases here and the patient's stroke symptoms will increase. I think if there are no more questions, I thank each one and all, and thank Medivision for giving me this opportunity to highlight one of the most important disorders of neurology, which can be the morbidity and morbidity of the disease can be brought down to a large extent if the people recognize the symptoms and take the patient to the hospital in time. Thank you very much.